Good day, everybody, and greetings from Canada. It is my great honor to present at this virtual AAP conference, and I would like to thank the AAP Education Committee for the opportunity to share and my experience of how I have kind of blended my two specialties together, one of periodontics and the other is of laser dentistry. For those skeptics out there, thank you so much for tuning in. And I do hope to make the next hour worthy of your time. So, of course, the pandemic has shown so many things to us, both on a professional and personal level. But one thing in Canada that I read recent data is that 75% of people do not actually know what a periodontist does. And when we are, perusing life as we're sitting at home away from our practices, I went on the AAP website and I tried to find out what we actually do for a living. And nowhere on the website did it actually say that we save teeth. And really, that is our prime directive. And now, of course, is the challenge of salvaging implants as well, which is supposed to be the exact same as saving teeth, which, as we know, is not the issue. And so we all had emergency clinics in our respective regions. And one thing that came out of the knowledge that people were able to go and get their pain taken care of was that teeth were extracted. And only when there was an endodontic lesion was the endodontist called in to the office to salvage the tooth and trying to keep the tooth. Whereas nowhere on anyone's radar was the fact that periodontal emergencies also don't necessarily need to end up with teeth in the bucket. And I think this is almost like a metaphor for the rest of our profession as to what we are facing. And we know all this data, the challenges that we are facing is that, of course, the majority of people have periodontal disease, and why it is not being treated to the way we were trained in graduate school remains a huge, huge hurdle that we need to figure out how to get over. Our referrals have been declining for a decade at least, and the majority of referrals are made too late, whereas we could have salvaged the tooth and saved the patient an implant. But the problem is, I think, in my humble opinion, that we have been clumped into the compartmentalization of dentistry. And periodontics is not compartmentalized. It is a holistic approach. And this is where we need to hopefully address this issue. And as I'm sitting there thinking on life as at home, I was thinking, well, why are people not referring? And simply because, we have compartmentalized things to the point where patients are not being referred because they always end up in this rabbit hole, this black hole where they never come out of. We'll go through the exam, the initial therapy, the reevaluation, surgery or not surgery, but in essence, they end up in our office for maintenance because they're not just a simple scale and root plane, and they do have an inflammatory disease that is not curable. And how we communicate that and not treat like we did in the 1600s when we knew plaque caused pockets is our challenge to communicate to the public. And now, of course, with the huge tsunami of periumplantitis that is going to be hitting us, it is exactly the same thing. But unfortunately, salvaging an implant is nowhere as predictable as salvaging a tooth. And so the principles that we are able to be trained with early on are things that need to be adapted and evolved. And so no longer is osseous surgery going to have to be the main focus of how we treat advanced or chronic periodontal disease, simply because the optics of it is just negative from the patient's perspective, but also the referring dentist perspective. And when we learn how not to cut out the disease and treat it much more holistically, I feel that we will start to battle this. We cannot just scale the calculus and assume that the pocket will heal. We cannot just cut out the granulation tissue and hope that there'll be reattachment of the flap in a stable new attachment, not just a long junctional sulcular epithelium. And we already know from Wilderman's study that wherever we want to use our handpiece and adjust the osseous structure in a positive manner to reflect that the flap sits passively, we know that the osseous structure doesn't remain. And so is this a valid option as well down the road? And so, of course, most recently, and I was encouraged by the AAP forum to completely change this talk as to all the amazing things that lasers could do to keep it really basic as to we save teeth, and the laser is going to help us to do it a little bit more efficiently and more predictably as well. So no longer can we throw antibiotics into the pocket locally or treat the patient with systemic antibiotics just because we are ineffective at removing the inflammatory factors, which is in this case the biofilm. And so if we can kind of go back into our periodontal history and analyze how we would sit in the pocket and think certain bugs were the worst and were the inflammatory factors, to the point where we went from non-specific plaque hypothesis to specific plaque hypothesis to, in 2008, being reclassifying periodontal disease as an inflammatory lesion, then inflammatory disease, then we can definitely justify the oral systemic condition that we are trying to convince the public and our referring dentists for. So we definitely have to come out of the pocket and think of it as a non-compartmentalized syndrome. And we are just as importantly to educate the hygienist as well. And so we have to just stop treating the pocket per se. And over the pandemic, I read this amazing book. I do encourage you to read it, and the analysis and the metaphor of how trees communicate under the ground through this amazing network of communication, of identifying where one area of the forest has a disease, for example, and that how other areas of the healthy forest can supplement and communicate over miles. It's just amazing, because I think that this is exactly how inflammation in the body, triggered from the calculus or the pocket, can trigger through the whole body. And this is, if we can get our mindset around the fact that biofilm is exactly the same, then we can reclassify our story of periodontics to something a little bit more appetizing for the patient and appetizing for our referring doctors and hygienists as well. So we all, for those of us who have kids or have seen the movie or and read the book, The Lion, the Witch, and the Wardrobe, story that I want to kind of think about reclassifying from the periodontal viewpoint is the biofilm, the sulcus, and the immune system. I feel that this is going to be our story. So if we can really understand that the biofilm and the efficacy of removal of the biofilm is the secret to our success in periodontal treatment, then I think we can really understand the fact that there's biofilm not only on the actual root surface, but also on the alveolar surfaces of the pocket or the bony defects, but also the sulcular lining. And more importantly is how that person's immune system reacts to the biofilm on the inner pocket and then the outer pocket. So with that, I will progress to the fact that we know, and lots of data to show, that mechanics and scaling and root planing our roots and mechanically drilling away the alveolar structure or mechanically cutting out the granulation tissue is just not adequate enough to remove the biofilm, to the point where we're unable to access things with the instruments at our hands. So we have actually historically adapted the person to fit our instruments. we create open furcations so we can get our 13, 14 into the furcation area that we think we're getting in there. Obviously, we're not. And how much are we going to adapt the patient to the archaic tools, mechanical tools that we have? So we need to kind of, again, hopefully rethink how we're doing the access aspect of periodontal treatment. Our other colleagues in dentistry, our endodontic friends, and of course even our restorative friends have long identified the mechanical removal of smear layer in a root canal system is just not adequate enough. They have already started to use lasers to a very great extent to create a better surface, biofilm free, in order to create a better seal, get into lateral canals. Our restorative colleagues have known this forever, that chemical removal of smear layer gives us a much better adapted restorative result. And from a periodontal viewpoint, though, our biofilm is not contained. We're not, again, compartmentalized as far as a restorative or an endodontic system goes. We have a much greater challenge, and that is that the biofilm is not just a piece of calculus left under the distal aspect of a molar, and we can only see it when we flap, but the biofilm, like our trees in nature, is a very complex system of pathogens, viruses, bacteria, amoeba, parasites, whatever you may count in that pocket, is embedded in this organic matrix, which is so viscoelastic and wanting to evade any mechanical instrumentation, to the point where we have bleached these in vitro, and it's still not adequate enough to remove the biofilm from the dentinal tubules. This is an amazing SEM from my Instagram family led me to this site, where you can actually see the biofilm on the root surface embedded into the dentinal tubules of plaque. And this gives us an idea, this beautiful art picture gives us an idea of why scaling and root planing, or even mechanical cavitroning, is just not enough to remove all these dentinal tubules filled with pathogens. And so we have the ability in vitro to remove biofilm off a root. And we know that citric acid, EDTA, enamel matrix protein all have the ability to have a beautiful blood clot form on the dentinal surface. But the fact is that these are in vitro studies, and we're able to measure it. How do we do that in an in vivo situation and try to save teeth, create a surface that is friendly electrostatically, and also for the fibroblasts to create a stable blood clot? We cannot GTR every surface. It's not amenable, and it's not practical. And so, we have tried this. We have shown also that, in vivo, that Garrett was successful, and the ability for Chrysler to measure the fact that we have very stable blood clot, but the surface has to be contained and is not necessarily applicable to multi-surface root surfaces. It could be one pocket or one connective tissue graft. But it is very, very difficult to do this across the board in a flap or a chronic perio kind of situation. We have McGuire showing us that this indeed is successful if you are able to use Emdogain and compare it to a connective tissue graft, and showing that new connective tissue fibers will form because the clot is stable, because the surface is biofilm free. So you can get stability of connective tissue fibers over years, a decade. And yet, how do we translate this into a chronic periodontal situation is the challenge. And so now, with the ability to now see that periumplantitis is also going to be a big problem for us, we need to be more and more aware of our other options of removing biofilm other than mechanics, other than perio wave, which is low-level laser, which we do not have the ability to have success at biofilm removal. We can certainly cut out the biofilm, but certainly aesthetically, this is not an option for our implant patients. And finally, the ability to use chemicals and citric acid and phosphoric acid is there as well, but certainly not a satisfactory result for the long term. And so this is my point at which I will introduce the idea that we need to kind of change our thought process. And if we are able to understand that a laser is not a magic bullet. A laser is not a laser, is not a laser, as my colleague Dr. Sam Lau has said in the past, is that you have to understand how a laser works. And coming back to our high school physics, it's all about the wavelength. And you cannot just take an apple and morph it into an orange and have it taste like an apple again. It's just not going to be a feasible thing, you know. So the key is to understand how a laser can remove biofilm off an implant surface, because we can measure this in vitro, and Yamamoto has shown this a few years ago in a beautiful paper in IJPRD, where he created a biofilm surface, removed it with the erbium laser, and didn't actually melt the titanium like in this situation. And so if you are able to remove biofilm effectively enough, you can actually get reosseointegration in a clinical situation. So let's look at our teeth again first and understand what a laser removing biofilm actually looks like here. And this is, as I mentioned right in the beginning, these are all my cases. I'm in private practice, just like all of you guys. And so, you know, you'll excuse the little shakiness of my medium person here. My dental assistant is just freehanding it. But I think you can observe the fact that the water coming out of my YSGG laser has a non-contact methodology in order to, if you will, power wash the biofilm off the root surface. Now, obviously, this is super gingival, but it is for demonstration purposes, because when we understand our laser parameters, we can place the laser tip into the sulcus and know exactly how it is going to behave. And if I can move on to the second part of our periodontal story, is the sulcular lining. And the sulcular lining is exactly the on-ramp to the rest of the body, how we're trying to communicate with our referrals and our patients as to what the key is to the risk factor of inflammation affecting our hearts and our lung and cancer rates, et cetera, is that there is biofilm obviously here. We can see that during the consultation. As a few weeks progress, when I'm able to treat the patient, you can actually see that there is a cesspool of bacteria on the inner lining, which has been fatiguing the patient, creating, of course, poor taste in their mouth, and creating almost a fever, pyrexia kind of situation. And so you can communicate to the patient exactly what is going on in the inner lining of the sulcus. But how do we remove this granulation tissue? You know, for those of us who've been in practice, we know that this is a very tenacious and challenging site to deal with. And how are you going to literally peel off the granulation tissue from the inner flap, which is now very thin and friable? How are you going to communicate to the patient as to how you're going to scrape with a scaler this granulation tissue off the socket wall? This is a very challenging situation as well. And it's chemicals are not enough. How are you going to mechanically tease these tenacious fibrils away? And with our papers that are coming out on the epigenetics of the sulcular tissue and periodontal disease, we now understand that this granulation tissue, which has been formed as a response to the local factors on the root surface for the patient's tooth, is now actually changing the tissue DNA, all the white blood cells, all the neutrophils. It's actually changing how a patient's local immune reaction to periodontal pathogens actually is happening. And so there's tissue memory here. So how are we going to deal with this? This is a real challenge for us. And how are we going to mechanically or even chemically remove this granulation tissue to make it look immaculate like this when we are doing a periodontal therapy for a patient in a quadrant or a sextant, for example? We have known for years that pathogens enter the sulcus. We just have been unable to deal with it except by actual mechanical removal with an incision or a split thickness flap, etc., to carefully tease the tissue out. But it is something that we have only been able to deal with antibiotics, because that is the only thing that has systemic circulation. But this is no longer going to be a big option for us, because antibiotic resistance across the world, not so much in North America as much as the rest of the world, is a huge, huge zeitgeist to be dealt with. And the third aspect is the whole immune tolerance of the patient to the insult, whether it's a trauma or it's a bacterial load or viral load or overall pathogenic load. We have no ability to predict who is going to respond to local factors and who is not, and who is a hyper responder versus a low responder. So this is something that is kind of beyond, obviously, this platform of discussion, but certainly is going to be the rate determining step of what treatment is delivered to patients and how. And so with that kind of brief history of a new thought process on periodontics, if I could refer you guys to the parameters that the recent journals have produced for us as far as lasers and treatment of periodontics and lasers and implants in North America. This is great. It's happening now. We have guidelines and structure as to how papers and studies need to be done. I'm just in clinical practice, so I leave it to the big experts to continue in this manner. But certainly we are finally headed in the right direction, because I do think that the treatment of periodontics and implants is best treated and most predictably with our laser technology now. So if I could make another metaphor, is that lasers is so similar to periodontics, in that the majority of dentistry is what we can see above the gum line, and the majority of periodontics is what we can see below the gum line. Laser technology is exactly that, in that the lasers we're talking about in dentistry and in healthcare are all the red lasers, the red laser light. And this little photograph of the two laser pointers that I have in my office are the red laser and the green laser. And of course, we're using green lasers more so simply because red lasers have the ability to blind people, and irritate people. But saying that, they don't blind people, they just bother people in the audience. But the thing is, red laser light has the ability to penetrate into organic tissue. That is the key. That is why medical lasers are all red lasers, whether they are the low, the mid, or the far infrared. It just depends on how far this red laser penetrates into tissue. And so laser action, to go back to a little bit of high school physics, but certainly to keep it very simple, I don't want to traumatize you as my physics teacher traumatized me, is that lasers work on two levels. One is what happens at the surface level, and one is what happens at the deeper level. And both things happen simultaneously, but the amount of surface versus depth is what signifies which laser people are using. It is not the marketing of the company. It is not showing you a one-off anecdotal story of, wow, I can cut a frenectomy, or wow, I can reduce inflammation by putting this laser in a pocket. It is not that. That is too simplistic. We must be scientists, and we must understand the physics of it. And this is what my master's in laser explained to me, why I'm getting the results that I was getting. And so the laser action at the surface, water lasers, which are the erbium light lasers, have the ability to not only ablate tissue, tissue epithelium or bone or biofilm at the surface, but also have the ability to penetrate deeper and work at a low level, low dosage, ability to reduce inflammation. And this is physics. This is not marketing. This is not one company versus the other. This is physics. And so you, with the, to expedite things a little bit, you can go back and listen if you so feel inclined. But the YSGG laser can be used in a contact and non-contact manner. One is that if you use it in a contact manner, a non-contact manner, you can stay away from the tissue and literally power wash and cut tissue away. If you are wanting to touch the tissue and get a tactile feel for the bone or the tissue or the root surface, then you can actually put the laser energy closer, the tip closer, and the laser energy will translate into the tissue and find water in the actual tissue, the bone, the gingival epithelium, the mucosa, etc. And the beauty of the YSGG laser is that it has two targets. That is water and hydroxyapatite. And the last time I took physiology, I think you would agree with me, that is all that the human being is actually made out of, is mineral and water. And so this is why the YSGG laser is more effective in the periodontal sulcus, because we have tooth, bone, and gingiva all at the same time. And so if we are able to use physics to calculate the amount of penetration versus the amount of action at the depth, then we are able to calculate that in vitro. The beauty of physics is that it's all numbers and it's able to be measured. And so we have the Goldilocks penetration of 25 microns cutting at the surface versus 2.3 to 2.28 microns penetration into tissue. And this is my table. I've calculated all this from all the data and the learning and the literature from my studies in lasers. And so this is basically what I would call the Goldilocks penetration to surface ratio. And as we've already chatted about, all red lasers do not do this. The depth of penetration varies according to the wavelength and the tissue that you have touched. And so with this complicated, non-complicated ratio, you're able to actually figure out if you are wanting to treat the periodontal sulcus, or if you want to do muscle injury therapy, you would use a deeper penetrating laser, red laser 810, because you want to get deeper to the muscle, but you want no action at the surface. We want both things in the periodontal surface. We want to cut at the surface layer, but we also want penetration of energy for faster healing, but also local capillary action for hemostasis. And we don't want coagulation, we want hemostasis, because we have better healing when there is less bleeding, but we need just enough bleeding in order to get healing as well. So this is why this table that I had showed you earlier shows us the perfect surface to depth ratio. So if we are able to, make a big leap of faith to say, yes, laser technology is for us periodontists to do periodontics better, then there's certain things that we were doing pretty predictably, but were kind of unpopular. And we definitely are not a big fan of soft tissue grafting. If you're the patient, are you going to take something off my palate? Or I had flap surgery all over my mouth and now their pockets are back. Or there are certain things that we were just not able to treat very predictably. Sometimes GTR did really well and sometimes it didn't. There are certain refractory cases that we were just throwing antibiotics at because we just didn't know what to do. And of course, the big black hole of periumplantitis is going to be a challenge. So if we can appreciate the fact that biofilm removal with water and laser energy is much more efficacious and much more predictable, because now we're going to have science to prove it, then I think that we have a real tool in our tool shed, and possibly, in my opinion, the only tool in the tool shed that we will need from henceforth. And so the pocket anatomy is so indicative of all the tissues in the mouth. We have granulation tissue, we have gingival tissue, we have alveolar tissue, and we have biofilm. And so the periodontal pocket is the perfect experiment in which to show you that we are efficacious at what we are doing, because what we want to do is create a biofilm-free surface that blood clot can mechanically grab onto, because it is a virgin surface with open dentinal tubules not filled with biofilm, to the point where it clots literally by itself and then has a stable situation so that gingival epithelium is not ingrowing and healing with sulcular tissue again. And so if we can imagine that we want to create two sides of Velcro that want to stick together for life. And so if we go back to our traditional periodontics of how we were treating patients with less than 4 millimeter probing depths, 4 to 6 millimeter probing depths, and greater than 6 millimeter probing depths, if I could suggest a alternative treatment protocol, in that we would have surgical curettage and ENAP per se, removing the sulcular biofilm and granulation tissue, replaced by a term called microflap. If we could replace modified Widman and minimally invasive flap to a mini flap, or as BioLase calls it, a repair technique. And finally, our traditional osseous flap with Becker's papers, etc., replaced by something called a macro flap. So micro, mini, and macro is just simple, and I will try to demonstrate that in a situation such as this, where we have less than 5 millimeter probing depths. We have the inability to instrument this root surface because it's too inflamed. Our instruments are not fine and delicate enough, on top of which there is biofilm and granulation tissue on the inner flap. So if we were to treat in a surgical curettage methodology that Yukna has shown us, then literally 5 days later, you will have removed the biofilm off both surfaces, created two sides of Velcro that want to be together. That's the way Mother Nature planned it and designed us human beings, and it is very, very easy to see the lack of inflammation even after 5 days. If the same situation is treated with the incorrect wavelength, as Charlie Cobb showed us, then this little piece of calculus, which we cannot see on the facial surface, is treated with the wrong wavelength. The energy penetrated too deep at an inappropriate setting, and not only removed the calculus, but also removed the alveolar structure as well through damage from heat out of the laser, not just red light as well. So it is about the wavelength and the depth of penetration. If we were to have a similar deeper probing, but a equally inaccessible site in which to place our instruments, you are able to place a laser tip, as you can see the aiming beam, and go down literally 14 millimeters and have little pieces of calculus and biofilm completely fly out, and therefore create a biofilm-free root surface. You are also able to remove all the granulation tissue adjacent to the root surface with biofilm on it, and therefore create two virgin sides of Velcro. But we know this alveolar regeneration is not magic. I did not bone graft here. We have a 3-wall defect which was just demineralized due to inflammation and local factors. And once you remove the local factors and the biofilm, then you create a regenerative situation because the blood clot is stable. This is excluding the epithelium by nature because we know our physiology and it's not anything more fancy than that. So if we were to have a deeper periodontal defect, which we wanted to do some minimally invasive surgery, and as our Cordellini group has shown us years ago, is that you are able to raise a mini flap based on Steve Harrell's MIS flap, minimally invasive sulcular flap, and you are able to get regeneration with reattachment of connective tissue, creating osseous structure and no recession. And that is the key. The clinical attachment level has been maintained. You don't have the ingrowth of the sulcular epithelium. And so in a recent paper that the McGuire group and Don Clem heading the group up just published this paper in Journal of Perio, and I do encourage you to look this up, showed that their results of this minimally invasive technique that Cordellini designed compared to repair technique has equal results, but a better patient outcome and a more speedy technique in the clinician's hands. So we are able to mimic what the most minimally invasive technique we had prior to laser technology has provided us periodontists. So if you were to take that same mist technique and challenge yourself and do a minimally invasive flap across a quadrant, then you are able to actually follow the steps that are shown in the paper that Cordellini has shown, where you're able to do a mini elevation, remove the inner granulation tissue, remove the granulomatous attachments on the root surface, and also do a little bit of osseous therapy as well in the removal of granulation tissue from the osseous structure, those cancellous porosities that are harboring pathogens. And the whole technique, just based on Cordellini's work, is not raising the flap past the mucogingival junction, but still getting into the crater defect interproximally. And so you can take a quadrant like this and have reattachment by two sides of Velcro. You're able to remove this granulation tissue. You're able to move this granulation tissue, remove the biofilm off the root surface, but look at how immaculate the inner flap is. So once you have those two beautiful virginal surfaces, Mother Nature wants to reattach itself. It's like taking a splinter out of your finger. You don't take antibiotics for that. You just remove the splinter and your body will heal itself that way. And so you have the ability in a mini flap or a repair technique to get at calculus, which is so deeply seated. You're able to do some local GTR techniques. You don't necessarily need to do a traditional distal wedge. You can just do a gingivectomy and not need to raise a flap in order to exclude the epithelium. And you're able to finesse and remove that inner granulation by literally like paintbrushing the inner granulation tissue away from the surface as well. And so this was my thesis in that in comparing traditional flap techniques and including Cordellini's GTR mist technique, we were able to show that clinical attachment level was the reason you got pocket depth reduction. You didn't get pocket depth reduction due to recession, which is the main reason our traditional papers were exemplified by, you know, patients not liking it, right? Obviously a big open embrasures and sensitivity, etc. So, and I do think that when the McGuire group puts out their 12-month papers, that is exactly what they will find, is that pocket depth reduction is through clinical attachment, new attachment, not through recession. And that is a big bonus for us periodontists as well. So in that exact technique, you can see here that you have a mini flap done on the day of surgery. You're able to address all these inflamed tissues. You are able to suture closed on the day of surgery. You can see the blood clot here, and definitely the improved results 1 week later, but not due to recession, but more due to clinical attachment through connective tissue. And this is the lower. You can see the difference in tissue texture. You can see the lack of bulbous inflamed tissues. You are able to see that there is a lack of significant recession. But more importantly, the patient experience is far superior than anything else compared to flap surgery in our clinical practice, for sure. Talking about pockets that are deeper than 6 millimeters, where we definitely need some, in this altered passive eruption type of case, a way to address the osseous structure so that the flap sits passively. We do the exact same thing and raise the flap with laser. You are then just removing accretions with Cavitron. But after that, laser follows through and removes all the granulation tissue on the inner and the outer flap interproximally. But more importantly, is using the laser itself for osteoplasty. We need to have a nice architecture here for the flap to sit passively. This is how we were traditionally trained. There is nothing different that we are doing except we're using laser technology and the ability to target hydroxyapatite and water at the same time. And so you can pick and choose to do osseous here, but not osseous here. And yes, it does have this roughened appearance because it's the laser doesn't carpet bomb and drill everything out and create more biofilm, but actually it removes osseous structure the way Mother Nature removes osseous structure. This is an osteoclast resorbing bone. It's more of a Pac-Man kind of situation as opposed to carpet bombing it as far as using you know, a number 6 round burr or something like that. And we know the nicer we are to our osseous tissue, we don't overheat it, and we are knowing that the patient's anatomy is much happier because you're not increasing the temperature to over 47 degrees. And now Soldatus has shown us that we are getting up to almost 100 degrees if we use a handpiece. So how do you expect osseous structure to be happy if it's going to be literally a boiling point? So before and after, 1 week. Before and after, 1 week. You can see the difference in the gingival architecture just by your eyes. You don't need to explain the benefits of this as well. But remember, the root surfaces are not going to be sensitive like we have with traditional osseous surgery. Now we are in the business of saving teeth, and I just did throw this case in just at the last minute with encouragement from the conversation at our AAP forum. And in a hopeless kind of situation like this, you sometimes get patients that are wanting to try heroics, and no skin off my nose. I can always extract and bone graft and implant, but saying that, you know, if she wants to try, let's try. So again, same techniques: remove granulation tissue, remove biofilm, remove inflammatory tissue from the inner flap. You can see that the blood clot is taking already because of the retention of the roughened etched surface, so to speak. And on the day of surgery, pre-surgery, it was like this, and literally 1 year later, it is looking like this. Yes, it's a PA, et cetera, but saying that it only has M1 mobility, whereas previously it was M2 plus, just didn't get vertical on the day of surgery, but saying that, again, we had a 3-wall defect in which this regenerated. Now, these are not everyday type of cases, but certainly it does, lend itself to the fact that she may have a few more years with this tooth. It is not a be all and the end all forever and ever. That's not what we promise, but saying that it's in her head right now and she has time to make that decision. Periumplantitis. This is going to be our new prime directive, is saving implants, of course, as Dr. Harrell on the AAP forum said. I absolutely agree with him that the ability for us to catch a periumplantitis defect at the class 1 level as opposed to class 3 level will predict how predictable we are in our regeneration. Simply because now that we know that we can remove biofilm effectively off even an implant surface, and this is an in vitro tabletop, you can see the titanium oxide layer coming right off and fitting in between the threads. We don't need chemicals, and we don't need to do osteoblasty if we don't have to. And certainly Strever has shown us that this can occur only with the YSGG and the erbium lasers. And we have data to show that if we have a brand new implant straight out of the package and we contaminate it in vitro, you are literally able to remove all the smear layer off all these threads. And it is something that we definitely need to look at as far as the practicality of using anything else right now, as far as smear layer removal off a contaminated implant surface. And the proof is in the pudding, because basically it's about how it translates into clinical care. I have one case that can demonstrate this for you to observe today. In 2004, we had periodontally involved teeth. Now, in hindsight, I would not have removed these, but saying that it is what it is. 2007, after socket preservation. 2008, everything is restored. Patient is happy. As usual with all successful implants, the patient drops off the planet literally until they have an issue in 2012. And Buckley calls this a foreign body reaction of BioOS. Certainly something we need to look into. This is the dentist x-ray going, your implant has a problem 4 years later. We do periumplantitis therapy, re-bone graft the area, and this patient is the most diligent and loyal PHT patient that I have right now. He literally makes sure that he is in every 2 to 3 months to the day, because he does not want to go through this again and lose implants. And certainly the stability is, by x-ray, you can see that this is something that is really doable if we catch it as early as possible. This was not the most ideal, but even then you are able to get regeneration. Now, am I going to biopsy it and take it? Obviously not. But if it looks and walks like a duck, hopefully it is a duck. And so the key is to understand our laser parameters so that when we catch periumplantitis starting for whatever reason, we are able to use our appropriate settings and place it in the circumferential defect, because implants are not growing bone by themselves after they are inflamed and infected, but certainly it is the alveolar structure, the four-wall defect, which is going to be our savior. So the earlier we catch it, the more chance we have for alveolar regeneration, bone grafting, and whatever your protocol is. This is exactly the stage at which you want to catch it. And this is why we need to have continual monitoring of our implant patients, because this is the whole issue if we can get to it sooner rather than later. And certainly if we have locators and patients with dentures, some of these all-on-4 cases, it's absolutely impossible for the patient to get in and around. This patient was converted from an all-on-4 situation to locators because of age and dexterity, etc. But certainly she was having a real tough time managing the tissue. But the ability of the YSGG laser to penetrate into the tissue and create an anti-inflammatory type of reaction in the gingival tissues is very evident here. 1 week post-op, you can see the tissues are starting to recover just by removal of the biofilm off the implant, but also that tissue memory, that sulcular granulation tissue, which is causing inflammation for the patient and bleeding, etc. And certainly we have to, there's discussion on failing implants, might as well just remove them. Well, I mean, this does not go over well in practice. As you all know, it's so easy to say that, and hopefully it's not your patient. That's also facetiously funny. But, with the number of implants that are being placed right now, that's just not a practical thing. And there are many, many papers coming out, and these are some of the few ones that I picked up, saying that replacement implants actually have a lower success rate. And Buckley is a big advocate of following this, and basically he is saying there's something happening at the site that is causing either implant failure or certainly implant refailure after replantation. And Nelson has a beautiful paper to show that the pathogens that were in the alveolus at the time of the tooth, the extraction, the implant placement, and the implant failure are all the same. So somehow it is how we take out the tooth that is the key right from the get-go. And just taking out a tooth atraumatically by not flapping and macerating the tissues, this is not atraumatic surgery. This is not how we are trained. We need to extract the tooth with finesse and with art. And if we have a laser instead of mechanical instruments to actually cut the tooth out of the socket, we are able to have these thin, friable, delicate alveolar plates and straps of bone upon which we can socket graft and create a decent ridge, and therefore have the ability then to place the implant adjacent to the natural teeth at the same emergence profile as the natural teeth, and not create a big bony embrasure space that is catching food and particles, etc. So the more atraumatic we are, the less mechanical we are. And just elevating gentle and really, really slowly is not necessarily the answer anymore. Secondly, the socket is filled with granulation tissue. We've already discussed this with respect to the periodontal flap. And so all these little granulations, how do you remove them? How do you peel that granulation tissue off the root surface, off the little canaliculi and into the little concavities of the socket without damaging the bone, without damaging the adjacent teeth, without damaging anything, and literally acting like Photoshop Adobe and just deleting it, and then having the patient's body recover and heal thyself? This is really, really an interesting way of trying to take out a tooth. And so before the socket is curetaged with laser, and after, you can see the beautiful little canaliculi filled with natural and healthy blood. Obviously, we know that we've ablated the granulation tissue, but we've also had laser energy penetrate into the alveolar sulcus, and we know that there is not only an antibacterial effect of it, but also an anti-inflammatory aspect of it too. In this kind of situation, I think it can demonstrate to you the ability of this tooth with a poor prognosis extraction, where you have no keratinized tissue, no attached tissue here, how you can literally peel off the granulation tissue from that aspect. Then you can decorticate, quote, or corticoabrade the socket in order to create a nice, beautiful, virginal alveolar socket upon which your grafting will heal beautifully, because vascularity is moving in nicely without pathogenic influence as well. And the key to success, of course, is how long lasting is the implant without any implantitis or periimplant mucositis. So I think we have a tool, because its target tissue is water and hydroxyapatite. It is the perfect kind of thing to use in an alveolar socket, because you can see here it's not burning the bone, it is not melting the bone, it is just stimulating the bone by ablating the negative, which is the granulation tags there. And finally, if we were to do this, sorry for this video, but saying that if we were to use the laser at the appropriate settings to remove granulation tissue in the surrounding socket, but also to remove biofilm off the implant threads. You can see the ability of titanium oxide to basically be deleted and how the surface is shining without melting. This is the key, again, to creating an implant surface which will allow osteoblasts to move in if it is a 3 and 4 wall defect, and even a 2 wall defect. You know, we're not going to debate how to do implant salvage therapy. There's many different recipes out there, but I just presented this video as a demonstration to show that there is no damage to the implant surface, and yet we are removing biofilm and toxic oxide layer, which has been created due to exposure. And finally, Dr. Lin had produced this paper out of IJPRD about the ability to remove palatal donor tissue in a grafting kind of situation, where he literally de-epithelialized the palate and then remove this remove the connective tissue in order to do a connective tissue graft. And this is after de-epithelialization, and this is after removal of the connective tissue graft. And the ability for us to have just the right energy to penetrate, to create hemostasis, but not full cautery of all the vessels in the area, which can happen with ND-YAG or various diodes that are out there. So this again falls into the neighborhood of how we change the optics of how we can take the tissue from the palate a little bit better and a little bit more efficaciously and with more speed as well. So with that, I will conclude. I want to outline how we've discussed the fact that erbium lasers are able to be used on all tissues, especially the bone, the implant, and the mucosa. We are able to access in a most minimally invasive manner. And because of laser energy penetration, we are also able to be a little bit more anti-inflammatory than a mechanical device, and therefore also atraumatic. But most importantly, it allows us to be artists. And a laser lecture is never complete without quoting Albert Einstein. And after a certain high level of technical skill is achieved, which we do in graduate school, science and art need to coalesce in aesthetics, plasticity, and form. The greatest scientists are always artists as well. I do thank you so much for your time, and please enjoy the rest of the conference. I'm sure it's going to be amazing.